Hello, ladies and gentlemen. Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I have been a cardiologist for more than 40 years in the Houston area. The focus of this presentation is ACC AHA 2016 guidelines for peripheral arterial disease, or PAD as it is called. So we're going to take a comprehensive look at what is peripheral arterial disease, how does it manifest, how do we diagnose this one, and how do we determine what is the appropriate treatment for these patients based on their clinical presentation. So let us continue with the feature presentation. The 2016 ACC AHA guidelines were published in circulation in 2016 for management of patients with peripheral arterial disease. We used to call this as a peripheral vascular disease back in the 80s and 90s and 2000s, but the correct terminology today is PAD, which stands for peripheral arterial disease. Because PVD referred to arterial disease, venous disease, and lymphatic disease, and static edema and things like that. So this is more in tune with what we are really talking about, that is the occlusion or the arteries or the bypass grafts supplying the lower extremities. Approximately 8.5 million people over the age of 40 years in the United States have some degree of peripheral arterial disease or symptoms related to peripheral arterial disease. Most of these patients are underdiagnosed, and even when they are diagnosed, largely they are undertreated for their diagnosis. And this has to do something with the education of the public, and more importantly, education of the clinicians, the nurses, the primary care doctors, and even cardiologists in recognizing peripheral arterial disease symptoms. Early recognition and aggressive risk factor modification would make a big difference, but somehow we are missing that particular aspect. 1/3 of the PCPs don't screen for peripheral arterial disease. And I'm going to tell you, we don't need to screen every person walking into the clinic. If you're seeing 40 patients, if 20 of them are like below age of 20, we don't need to screen those patients. But if you have 10 patients who have multiple risk factors, which I'm going to talk about in a minute, they need to be screened for peripheral arterial disease. It's a very, very simple test that can be done in the office with the equipments that you already have. And in fact, you would be doing a great service to your patients if you can do this test at least once a year to see if these patients have peripheral arterial disease, especially in the presence of multiple risk factors. Then those patients can greatly benefit by risk factor modifications and medication and guideline-directed medical therapy. Only 6% were aware of the PAD guidelines. They didn't even know we had guidelines for peripheral arterial disease. There were guidelines in 2005. The next guidelines came out in 2016, and that's what we are referencing in this particular presentation. And as a matter of fact, peripheral arterial disease is the third leading cause of death after coronary artery disease and stroke. So that should underscore, if we are spending so much time, money, and effort and resources on coronary artery disease, prevention of stroke, we should be focusing on peripheral arterial disease equally well, because it is number 3 cause of death in patients over the age of 40 or 60 years age. The risk of cardiovascular deaths in patients with peripheral arterial disease is double if they have peripheral arterial disease compared to those who do not have peripheral arterial disease. 5% of the people over the age of 40 to 45 years have some signs and symptoms of peripheral arterial disease. 12% of the population over the age of 70 to 74 have peripheral arterial disease. When patients develop chronic limb ischemia, characterized by reduced circulation, cold extremities, some degree of gangrene, discoloration, poor sensation, all of these are signs of chronic leg ischemia. 1 in 5 will need amputation within 1 year. And this is a place where we as internists and cardiologists and clinicians, where we can really help these patients by early detection, serious risk factor modification, and guideline directed medical therapy for peripheral arterial disease. Anyway, the initial diagnosis can be made at bedside. All we need is a stethoscope and a blood pressure cuff. You measure the brachial pulse. Mainly we are interested in the systolic blood pressure, and you measure the ankle pulse, the systolic pressure. And if you have a Doppler, which most primary doctors do have in their offices, or get one, and then you can measure the systolic pressure in the brachial artery and the systolic pressure in the posterior tibial artery. If the ratio of brachial versus the posterior tibial artery is less than 0.9, it is diagnostic of peripheral arterial disease. But there are a group of patients who have significant atherosclerosis. They are stiff arteries and they don't give proper readings. In those patients, we can measure the toe brachial index. It's called the TBI. And if the toe brachial index is less than 0.7, it is diagnostic of peripheral arterial disease. If we are still in the borderline zone between 0.8 and 0.92, then we can do an exercise ABI, and if there's a drop, 20% drop in the index, then that is an indication of peripheral arterial disease. So this is a very simple test we can do in the office and try to find out whether the person has peripheral arterial disease or not. But most of the time, cardiologists or cardiovascular surgeons generally have these more sophisticated machines where you can put multiple blood pressure cuffs and look at waveforms, not only systolic pressure, but look at the waveforms to determine the location of the blockages. But from a primary care physician point of view, or from a general cardiologist who do not have these machines, just an ankle brachial index should be a great index of suspicion. Once we have that, then these patients can go for further diagnostic tests like CT angiogram or MRA, which will really give you a whole picture of their entire vascular system from the thoracic aorta all the way to the toes. Just like we are seeing here, as we can see, there is a native disease artery which is totally blocked off. You can follow the arrow, and here's a bypass graft which seems to be working. Now here again we have a total occlusion with reconstitution through the collateral branches. So it is important for us to establish the diagnosis of peripheral arterial disease. And there are different ways to measure peripheral arterial disease. We're just showing you some different ways. And the simplest thing is you measure the systolic blood pressure in the right arm. You measure the systolic blood pressure in the right ankle, which is like 68, 64. You take the average. Then you can do the same thing on the left side. You take the ratio which is the lowest. Like in case right brachial index was 0.57, so that is abnormal. So you take that one. On the left side, the artery might have been pretty calcified and hard, and sometimes we can get abnormal readings from that. That's why we need to measure both sides and take the number that is most critical. Okay, this is the waveform which I was talking to, which can be used. But let's look at what are the risk factors for peripheral arterial disease. So in that way, we can identify these patients. If they have 2 or more risk factors, they need to be checked with an ankle brachial index so that we can see if they are having peripheral arterial disease, and if so, what can we do about it? Smoking, the same risk factors for coronary artery disease, same risk factors for stroke, arteriosclerotic heart disease. We are dealing with the same population. Smoking, family history, hypertension, hyperlipidemia, diabetes, coronary artery disease, carotid artery disease, or people who have like abdominal aortic aneurysm or thoracic aneurysm. All these patients may be candidates for peripheral arterial disease, and these patients need to be on a yearly basis checked for peripheral arterial disease signs and symptoms. Talking about signs and symptoms, patients with peripheral arterial disease can present with history of claudication. It is not very often that we see classical intermittent claudication, just like angina. When you walk, you get chest pain because of reduced circulation. The same phenomenon works in the calf muscles. If you have significant stenosis leading to reduced blood circulation to the calf muscles here, when you walk, you get muscle cramps. When you stop, the cramps improves. Then you continue to walk, the cramps come back. So that is just like exertion-related angina. Then we also need to look at, there are other things that can cause pain in the legs. It could be muscle spasms. It could be related to electrolyte imbalances. It could be related to arthritis. It could be related to connective tissue diseases. So there are a whole host of other things that can cause similar symptoms or symptoms of pain and ache in the legs, which we need to be concerned about. There could be a muscle spasm or maybe trauma from hitting some furniture. Then we need to look for reduced circulation. Once we have established that this patient is having intermittent claudication or something close to the intermittent claudication, the next thing we need to be concerned about is, are there any ischemic changes in the leg? Sometimes this degree of stenosis is so critical, these patients may have pain at rest. Even if they just put their feet down, they can begin to have pain because of reduced circulation to the tissues beyond the blockage. Examination, of course, we need to examine their pulses as primary care doctors, as internists, especially in the high risk group. We owe it to check their pulses in both sides, both arms and both feet, and see if we have good pulses. If we are in doubt, do a ankle brachial index. Then also listen for vascular bruise and non-healing lower extremity wounds. In fact, when I was working for the VA hospital as a medical director, I had to see some patients, and one of the things we did was diabetic foot examination. It was so thorough in terms of looking for arterial flow, venous flow, skin discoloration, ulceration, gangrene, and warmth. A whole host of parameters had to be completed on the chart. I think we should follow the same principle when we do a peripheral arterial examination of a patient on an annual basis. It should be a separate examination altogether where we look for skin discoloration, loss of hair, bluish discoloration, and loss of sensation, loss of pulse, then some changes of gangrene or unhealing ulcer. All of these are signs of reduced circulation to the foot, and these are vital signs that will tell us that we are dealing with a more significant problem proximal to the issue we have on the foot. The ankle brachial index, if it's greater than 1 to 1.4, it is normal. Between 0.9 and 0.99, it is borderline. It is these patients where we can do an exercise test to see if there's a 20% drop in the index. Between 0.7 and 0.9, mildly abnormal. 0.4 to 0.69, moderately abnormal. And if the ratio is less than 0.4, you're dealing with severe abnormality. The main focus of this ankle brachial index is to find out, not to diagnose where the location of the blockage is and how critical the blockage is. That is going to be done by CT angiography or MRA or invasive angiography. But the key factor is to determine does this patient have any evidence of peripheral arterial disease based on the symptomatology, based on the physical examination, and based on this simple ankle brachial index. If that suspicion is proven to be true, then we need to proceed with other diagnostic tests such as CT angiogram or MRA, both of which are excellent. And with the MRA, we can actually look at the presence of the lumen and the wall thickness and the presence of blood clots like in aneurysm situation. So MRA has certain advantages. and here we don't have to use the contrast even though we use gadolinium, but nonetheless they are extremely useful in identifying the entire circulatory system all the way from the abdomen to the toes and see where the blockage is, how many blockages are there, how significantly the circulation is compromised, how are the collateral circulations, and what can be done if at all we can do something. Most of the time when we intervene in patients below the knee, the results are plus minus. It becomes a revolving door. They get the procedure, they feel better for a few months, they continue to smoke, drink, and do all these bad things, and they come back after 6 months. Again, they have to go for another procedure, or eventually it will progress on to chronic limb ischemia, leading to amputation. With this information on hand, let us see how we're going to sort out as what we do with the results of the ankle brachial ratio. Okay, let's start off with diagnostic test for peripheral arterial disease. We've done the physical examination, we've taken the history, we have done the ankle brachial test with the segmental limb pressures if we have the machine available to do that one. Non-compressible arteries, that is the stiff calcified arteries, if the ankle brachial ratio is greater than 1.4, then we can do a tibial brachial index. If it is greater than 0.70, then look for other causes of pain or any other symptoms that person may have. If the TBI is less than 0.07, then we look for life-limiting claudication. If they have life-limiting claudication, we continue the medical treatment. We also consider revascularization. When it comes to revascularization, if they are not a candidate for revascularization, we continue with the guideline-directed medical therapy. If they are candidates for revascularization, of course, we go through the route of CT angiography or MRA based upon their kidney function and other parameters. Then the decision is made as to whether we go for stent placement or surgery. So CTA or MRA is a class 1 indication for those symptomatic patients who are not controlled on medications with abnormal ankle brachial ratio or abnormal tibial brachial ratio. So ding, 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 this is how we come here. And then we look for anatomic diagnosis by using angiography, which is a class 2A indication. Now let's look at here. Now we have 1 to 1.4 or borderline ankle brachial ratio, 0.91 to 0.99. If that is the case, we do an exercise ankle brachial ratio. If the exercise ankle brachial ratio is abnormal, that is, we see a 20% drop in the index, then we go through this route. If it is not, then we look for alternative causes for pain or other symptoms. On the other hand, if the ankle brachial ratio is less than 0.9, we do the exercise ankle brachial ratio, and based on that, we're going to decide what needs to be done. And here they say, do not perform invasive or non-invasive anatomic assessment of asymptomatic patients. That's a class 3 contraindication. So please remember, this could be a board question, especially for cardiologists. So that's something you really need to keep in mind. Now let's proceed with the next slide here. When we are dealing with the guideline-directed medical therapy, of course, we're going to be addressing the risk factors in a minute, but these patients, if they are asymptomatic, we can consider aspirin, which is an antiplatelet agent. In symptomatic patients, all patients, they need to be on aspirin or clopidogrel, either one of them, or they could be on aspirin and rivaroxaban. Whereas if they have recent coronary stent or coronary syndrome, and obviously they are going to be on dual antiplatelet agents, and those agents should not only be helping with the stent, but it should also help with the peripheral arterial disease. If these patients are going for revascularization, surgical or endovascular, they need to be on dual antiplatelet agents like aspirin and clopidogrel for 1 to 6 months. Or they could be on aspirin and rivaroxaban. And high limb risk patients, intensive antithrombotic therapy with dual antiplatelet agents should be considered. So let's keep these things in mind. So in addition to diagnosing and intervening in these patients through either endovascular procedure by putting stents or any other options, or surgical bypass like aortofemoral or fempopliteal or femtibial, then they need to be on aspirin and clopidogrel for a minimum of 6 months. And if they have a coronary drug-eluting stent, they need to be on for a whole year, at least for that duration. And here is a guideline from the European Society of Cardiology 2017, which was about the same time as the American College of Cardiology came up with the recommendations. Asymptomatic patients, no antiplatelet agents are recommended. Symptomatic patients, we can have a single antiplatelet agent, either aspirin or clopidogrel. Those patients who are going for revascularization, either through stent placement or surgery, they need to be on dual antiplatelet agents. Then later on, they are switched to single antiplatelet agent. This is after a year, and then it's questionable as to what they need to be on according to this one. And the surgery is the same thing. This is a class 2B indication, dual antiplatelet agents or vitamin K antagonists. So this is from the European Society of Cardiology. All right, let's move on to the next saga in the patients with peripheral arterial disease, namely chronic limb ischemia. I told you about some of the features of chronic limb ischemia: cold, clammy skin, loss of hair, loss of shininess. There may be some bluish discoloration, loss of pulses, and there may be some unhealed ulceration. So when you have chronic limb ischemia, that is signifying more significant disease in the arteries in the leg, or it could be in the popliteal or the superficial femoral level. So in these patients, we can do an ankle brachial index, but I would straight move on to looking at a diagnostic test such as CTA or MRA to determine if they have significant abnormality, because based on this we know. Of course, we do the ankle brachial index. If it's less than 0.09, that's what we are concerned about. And again, in the border zone, if they have non-healing ulcer, yes, then we look for perfusion assessment, tibial brachial with waveforms and skin perfusion pressures. And if these are abnormal, we go to CTA or MRA. When it comes to peripheral arterial disease, the bottom line is where is the location, how many obstructions are there, how significant are these obstructions, and can something be done with these obstructions in terms of surgery or endovascular repair. And that is the main crux, because it's just like watering a yard. If you get no water, the yard is going to dry up no matter, and doesn't matter what else you do. So if you can reestablish the flow to the yard, then we can think about other things. So that's the way I look at it. If you're not getting any circulation to the foot and the lower half of the leg, then see where's the blockage. Can we improve the circulation with interventions to start with, and then with drastic modification of risk factors, and of course doing the exercise program to improve their physical capacity of exercise. When we are talking about chronic limb ischemia, this is an important topic I want to stress, that chronic limb ischemia is not a primary care doctor's problem. It is not a vascular surgeon's problem. It is not a interventional radiologist's problem. It is a comprehensive problem which involves multidisciplinary approach. It involves a vascular surgeon who needs to do a fempop, femtibial bypasses. An interventional radiologist or an interventional cardiologist can do stent placement, or even a surgeon can do stent placements to improve the circulations. We need nurses who are trained in managing patients with peripheral arterial disease, looking for pulses, looking for skin discolorations, and all the other things we talked about, chronic limb ischemia. Sometimes we need orthopedic surgeons if we have to do amputation or improving the toenail function, because these patients are prone for infection, they are prone for ulceration, they are prone for non-healing ulcerations. So the loving care of a podiatrist and orthopedic surgeons becomes essential. We need endocrinologists, internists, infectious disease specialists, especially if they have osteomyelitis. We need physical medicine and rehab people to rehabilitate these patients. And of course, if these patients have to go through amputation, they need prosthetic department involved. And wound care becomes an important part. If people are having chronic limb ischemia and if they are having non-healing ulcer, that's a whole different team which has to deal with that non-healing ulcer, which involves wound care team. Of course, the social worker to bring all these pieces of the puzzle together. Exercise physiologists to get them in a programmed exercise regimen to improve their tolerance for physical activities. Diet, nutrition, blood pressure control, and all these things go hand in hand. Now let's look at acute limb ischemia. Acute limb ischemia is a surgical emergency. I said it's a surgical emergency because if you have a sudden loss of pulse in a limb, which I have seen in my practice, I used to follow a many number of patients with peripheral arterial disease who were going for fempop or femtibial bypasses. I used to follow these patients routinely in the hospital and in my practice. So I am very familiar with the peripheral arterial disease, their manifestations. I have seen quite a few people who have gone through amputation. That is not a very good sight to watch, and try to explain to these patients that we have to amputate in order to keep them from getting pain, and even then some people keep having phantom pains. Anyway, getting back to acute limb ischemia, this is an emergency. Clinical evaluation including symptoms and sensory assessment and arterial and venous Doppler signals. We not only look for the arterial flow, we also look for the venous flow. We look for the skin coloration. We look for the capillary filling time, so that it tells us how bad the circulation is. Do we have audible arterial pulses? Do we have audible venous hum? If that is present, we have a viable limb, normal motor function, no sensory loss, intact capillary filling pressure, and if that is the case, revascularization is urgent and anticoagulation should be used unless contraindicated. That's a class 1 indication. If you are dealing with an acute limb ischemia, if the limb is viable, the muscle is viable, the skin is viable, and the capillary filling is intact, they need to be started on anticoagulation and then proceed further. If these pulses are inaudible, you don't hear any arterial or venous sounds, motor function assessment is intact, then marginally threatened slow to interact capillary refill. So the slow capillary refill, that's basically it is suggesting there is significant compromise in the circulation to that particular ischemic limb. Is it salvageable? Then we need to go for emergency revascularization. I remember a case who came with an acute cold limb. And this is a patient who had atrial fibrillation with perhaps clot in his left atrium. And sure enough, he threw a clot into the femoral artery. And when we did the femoral angiogram, when we did the arteriogram of the legs, we could see there was total occlusion of the superficial femoral artery. And this was a fairly easy case for my cardiac surgeon colleague, who could just open up the femoral artery and extract the clot and then reestablish the circulation. So it is an emergency to do revascularization and do embolectomy through a balloon catheter and put these patients on anticoagulation. So that is class 1 indication. On the other hand, if we have inaudible arterial and inaudible venous sounds, and if we cannot salvage the limb, of course, the last ditch option is amputation, which is a class 1 indication. Class 1 indication because if they are having gangrene, if they are having serious risk of getting sepsis, which can be much more life-threatening systemically, and that's why these patients need to be considered for amputation. Whereas in this, motor function is impaired, immediately threatened, slow to absent capillary pulse, loss of sensation in the toes with rest pain or mild or moderate muscle weakness. Then if the limb is salvageable, we go through the route of revascularization. So this is about acute limb ischemia. So ladies and gentlemen, when we are talking about managing patients with peripheral arterial disease, we are so focused on diagnosing it, but our enthusiasm kind of fades away after that. I can tell that from real practical experience, because when we deal with coronary artery patient, we are much more vigilant and we are much more effective in risk management in patients with cardiovascular problems, heart problems, like smoking cessation, antiplatelet agents, hypertension, getting lipid levels, LDL, by less than 50% of the level it was, or below 100, getting diabetes under control, and using some of these medications which may or may not help. I had one patient who felt better, who had peripheral arterial disease. He felt better on silestazol. I don't know if it was psychological, but they may or may not help. What's going to help is bringing more blood circulation to the area. And how can we accomplish that? And preventing further thrombosis or clot formation with antiplatelet agents. So we have to base our decisions on concepts of what's the underlying problem and how we can improve it. And certainly programmed exercise regimen can help some of these patients before and after revascularization. Influenza vaccine, I don't know why they put it here, but this was a recommendation by the American College of Cardiology and American Heart Association. Anyway, ladies and gentlemen, this is a comprehensive review of peripheral arterial disease and how underdiagnosed it is, and even when it's diagnosed, how much undertreated it is. So I think education of ourselves, like primary care doctors, internists, nurses, cardiologists, is of first order in trying to recognize peripheral arterial disease, recognize the degree of peripheral arterial disease, then do appropriate tests to look for location, look for chronic limb ischemia, and you must be familiar with what is acute limb ischemia in order to salvage those patients' limbs in a timely manner. Thank you so much for watching this presentation. I have a series of presentations on ACC AHA guidelines for practically every scenario, and there's a whole playlist there. I'm going to put a link here, and please do watch all of those, and most importantly, please do like our YouTube page. In that way you can support our continued effort to bring knowledge to each of us. Thank you so much.